For those that do not know me, my name is Alicia Majors. I have the privilege of working for the administrative office at Beaver County Behavioral Health, and I also oversee the Zero Suicide Initiative here in Beaver County. Thank you so much for attending today's safety planning training for the mental health professional. Today's training is sponsored by the Beaver County Zero Suicide Initiative. In just a minute, I'm going to turn it over to Dr. Matthew Winterstein. But before I do, I just want to touch on a few housekeeping items. Since we have such a large group, we do ask that everybody keeps their microphone on mute just to eliminate any background noise and feedback. We will have time designated at 2 times actually designated throughout our training this morning when folks will have the opportunity to unmute themselves and address any questions or offer any feedback that they may have. We will also be using the Q&A box and also the chat box located at the bottom of the screen. We have folks monitoring that throughout this morning's training. The only thing that we do ask is if you are going to submit a question, if you make sure that you start the question with the word question. So that way we can make sure that it is highlighted and does not get overlooked. All right, for those that are not familiar with the Beaver County Zero Suicide Initiative, I just want to very quickly give you a little bit of background. The Beaver County System of Care partners were interested in improving our system and learning more about suicide awareness and prevention. As a result, the Beaver County Zero Suicide Team Leaders Work Group, comprised of cross-system partners and organizations, started meeting in August of 2019 to roll out the 7 essential elements of zero suicide. The essential elements described throughout the Zero Suicide Toolkit provide us with a roadmap on how we can deliver safer, more effective care here in Beaver County. One of the essential elements is to train our workforce. So that is exactly why we asked Dr. Matthew Winterstein to join us today and offer this valuable training. He has a tremendous amount of expertise in this area. Dr. Winterstein is an associate professor and director of research in the Division of Child and Adolescent Psychiatry at Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. His grant-funded work supports his role as a facilitator at the Pennsylvania Higher Education Suicide Prevention Coalition, a collaborative partnership among nearly 100 campuses across Pennsylvania and beyond, designed to support one another in developing meaningful and effective methods of reducing suicide deaths on campuses. Dr. Winterstein also awarded a grant from Vibrant to expand Pennsylvania's coverage of the National Suicide Prevention Lifeline. Additionally, he was recently awarded federal funding to examine the effectiveness of comprehensive aftercare for suicide attempters, as well as support statewide efforts to improve continuity of care for individuals of all ages affected by suicide. He has served on national and international task forces convened by the State Suicide Prevention Resource Center, the American Association of Suicidology, the American Foundation for Suicide Prevention, the National Suicide Prevention Lifeline, Suicide Awareness and Voices of Education, and the National Institute of Mental Health. Dr. Winterstein was a consultant to the National Center for the Prevention of Youth Suicide. He serves on the Pennsylvania Governor Tom Wolf's Suicide Prevention Task Force and is on the executive board of Prevent Suicide PA after spending nearly a decade as the co-chair of the Pennsylvania Youth Suicide Prevention Initiative. Wow, that is a lot. So we are very honored to have you here today. Thank you so much for joining us, and now I'm going to kick it over to you.
Well, great. Thank you. Thanks so much for having me. Yeah, you never know if somebody's going to read the whole thing or if they're just going to post it somewhere and you can have it. It's always a little uncomfortable to sit there and listen to somebody read all that stuff again and again. But anyway, it's really exciting to be on with you guys this morning. I see some familiar faces, some of my college group that we talk with from time to time and so forth on here today. And so, really excited to spend some time this morning talking about safety planning Just to give you a quick agenda for what we're going to cover this morning. The first part's going to be more of a didactic training in terms of, here is the safety planning template. Here's how we work through it. Here's some ways to think about it. So all that stuff will happen first. Then there will be a pause sort of after that to address any of the questions that have popped up in the chat and see if there's any additional questions that you may have. And then after that, Lauren will join me and we will do sort of an impromptu like sample safety plan. She's going to pretend to be someone with something. And the interesting thing is we haven't had a conversation about it at all. So it's totally unscripted. And we'll see how it goes, but hopefully we'll get through it okay. But it gives you an opportunity to see kind of what's it really like when you're kind of, working through this stuff. And so we'll give you a sample of that, and then we'll do a little bit of Q&A after that in case there's any additional questions that perhaps have popped up in the middle of that segment as well. I like to sort of start when I talk about safety planning to recognize that in many ways, most of us in the behavioral health field have had some sort of introduction to safety planning at some point. What that was and what that safety plan looks like are sometimes highly variable from one place to the next. And it has evolved quite a bit over many, many years. I can certainly remember, gosh, I'm trying to think of how many, like 25 years ago, I guess it was, sitting there working as a psychiatric technician in an inpatient unit. And the concept of safety plan back then really was having people sign stuff that said they wouldn't hurt themselves. Like that was the go-to method at the time. And for whatever reason, we thought that was okay. Interestingly, the data has told us, more recently that that's really not very helpful at all. And actually from a legal perspective, it's probably more hurtful for you than you ever thought was. And so the purpose of today is to really talk about an evidence-based approach to developing safety plans, something that was originally developed actually in the VA system. And so I saw a couple people, as you guys were sort of chiming in with who you are and where you're from, saw at least somebody who chimed in that they're with a VA. If you're doing this stuff there, this is going to look very familiar to you. It's been in that system for probably 15 years. It's been adapted then to non-VA adult populations. It's been adapted for youth. And what they have found is that again and again, regardless of the population, it has been shown to be an effective way to mitigate suicide risk in the short term for people that could be struggling in the midst of a crisis. So that's really what I want to share with you guys today. So I'm going to share my screen and kind of work our way through part one. And again, as Alicia said before, if anyone has any questions, by all means, like in the chat, feel free to type out your question, but it's super helpful if in all caps you write the word question before you type in your questions, because sometimes people put in comments, those are wonderful too. But if we're looking for questions at the end to be able to address, then that's really important. So everybody should see the screen in front of you. There we go. All right, so we're going to talk about safety plans here. And moving forward, I do want to acknowledge some folks. Again, this was developed in the VA system probably at least 15 years ago. I can't take credit for that or the adaptation that we've had in terms of working with adults. We have been working a lot in Pennsylvania in terms of adapting this with youth. It's the same format. It looks very, very similar. And there's obviously some populations that this is not going to work as effectively with. We'll talk about that when we get there. But I do want to acknowledge folks like Greg Brown, Barbara Stanley, and lots of folks who are in the VA system who helped kind of put this together originally. So throughout this, I realize some of you guys are working a lot with adults and stuff too. So the word youth is in there frequently. I use the same slides. Sometimes it goes from a youth audience to an adult service focused audience, but youth is individual in this particular context. So how can someone manage a suicidal crisis in the moment that it happens, and what can we do to be helpful? I used to joke when I would go around and do talks and trainings throughout Pennsylvania that, it's not like and I also use the word patience all the time too. I apologize if that's not the word that you guys use. I've been in a medical setting for far too long, and that's just the word that naturally flows from everybody that I work with. So, we kind of make this, our patients are not with us 24/7. And so like the crisis sometimes happens in these moments, and should say sometimes, frequently happens in the moments when they're not with us. So we're not sitting there in session and suddenly the crisis emerges. That doesn't happen as often. It's usually when they're by themselves, or they're at home or at work, at school, wherever they happen to be. And so the real challenge is, what can we do to assist them in those moments to be able to take care of themselves? The cool thing about this process, as I see it, is it is absolutely it's a therapeutic strategy. It's not therapy, but it's a therapeutic strategy that helps to empower the individual who goes through these suicidal crises to identify and utilize strategies that they are already capable of doing to take care of themselves when and if crises emerge. And what we know is that individuals who experience thoughts of suicide will go through periods of time where that thought might emerge. Sometimes it just pops up and it's like, all right, something else comes in, distracts them, they quickly fall out of that. And other times they can really get stuck in a spot, and that could lead to thoughts of intent, thoughts of action. And the goal here is, again, it's not therapy. We're not trying to solve the why in the world do the suicidal thoughts occur in the first place. Our job with this intervention is simply to prevent the person from doing the behavior that could end their life. Plain and simple. So the way to think about it is, there's really kind of two things listed here. You got your assessment and you got your referral or treatment. I like to think about this as, that purple arrow really just represents time. So the top is time 1, the bottom is time 2. It just says assessment and it says referral and treatment at the bottom. It could happen at any point in time. I'm sure all of us have had experiences where you're working with somebody at intake. We ask if they've been having thoughts of suicide. They say no. And what we discover 3 weeks later is, in fact, they've been thinking about it quite intently. And we're thinking about it 3 weeks before when we first met them, but they were uncomfortable at the time sharing or whatever it might be. The point is, this can be implemented at any point during any sort of therapeutic contact with somebody. So whether it be assessment to treatment or session 2 to session 3 or what have you, there's a gap of time in which we need to, that purple arrow is that time that they're not with us. And so that's the time that we need to make sure that they're able to care for themselves. It's not a no suicide contract. That's what I was referring to at the beginning. Like I said, we used to have people sign those kinds of things and as if that was going to be helpful in some way. So for those of you that have been in the field for a long time, you know exactly what I'm talking about. For those of you that are fairly new, hopefully you have no clue what I'm talking about. But these were oftentimes in inpatient settings, people would sign, they'd be asked to sign something that says, I will not kill myself without talking to you first, or something like that. And then they would sign it. We'd enter it into the chart and we'd be like, oh, that somehow is protecting us in some way, as if that would be a deterrent for persons actually to not engage in those types of behaviors and suicidal behaviors. As you can imagine, the data on this is overwhelmingly against and opposed to this. They have found numerous occasions where, if you actually look in psychiatric inpatient units back 10, 15, 20 years ago, if you look at those inpatient units and you identify who signed those contracts versus who didn't sign those contracts, what they find is that people who signed the contracts were significantly more likely to make suicide attempts while in the hospital than the people who did not sign the contracts. Now, the argument could be made that the whole thing's confounded by the fact that the only people we have signed these contracts are the ones that we're worried that might be suicidal. But the point is, they're not effective. And more importantly, they tell people what not to do. Now, again, as a therapist, I don't spend my time telling people, oh, you should do this and you should do that. I tend not to be directive kind of in that vein. The only times that I do kind of get directive, if somebody is clearly suicidal, unable to take care of themselves in that moment, we're in the midst of a conversation and they need to know, do this to take care of yourself, I will give them that information. The point though is, developing these safety plans often empowers them to have that information when they need it, such they don't need me to solve these issues for them. So it's not a no suicide contract. We're not telling people what not to do. In fact, the important thing about this is that we are telling people, or we're not telling people, we're helping them to identify the things for them to do when they are feeling suicidal. And just a quick little last note on this, from a legal perspective, so I know an attorney down in Dallas who is, how do I want to say it? He only tries about 3 or 4 cases a year. They all tend to be wrongful death cases that are around suicide. He wins all of them. He doesn't get involved in the case unless he wins. And his stance on these no suicide contracts is, if something like this is in place, the first thing a good attorney is going to do. So let's say you have somebody sign these no suicide contracts. They then go home, die by suicide. The family is upset. They decide to sue you because upset people sometimes do those things. They decide to sue you. The attorney then says, I need to see a copy of all the records. They subpoena your records. There's a no suicide contract in there. They look at that, and the first thing they're going to ask you is, did you assess them for competence when you asked them to sign this contract? Now, for most of us, the answer to that question is going to be no. And as soon as we say no, the next question is, how many zeros should I add to this, finding? Because in essence, you're going to lose. So here's where we have the issue. It's not helpful. It doesn't tell people what to do, and that's what we're trying to aim for. So what is a safety plan? It's a prioritized list of coping strategies and resources for people to use during a crisis, provides a sense of control. It's brief. It doesn't take a long time to do this, but as we'll probably discover in the second half of our time here today, it's not something that we usually knock out in the behavioral health field. This is not something we knock out in 3 or 4 or 5 minutes. Sometimes people try to do it in 3 or 4 or 5 minutes in emergency medicine. Sometimes that's effective. Other times they need a little bit more work. But the key thing to this is a commitment to treatment. And the example that I like to give people is this, that at Jefferson, where I work with a lot of psychiatry residents in training. And one of the things that we historically had done was what they called mirrored cases. And so you would have one of the residents would get paired up with one of the attendings, and the resident would come in with all the other residents there. The medical students are on rotation with us, and one of the attendings, and basically say, here's a case that I'm working on that I'm struggling with. They would kind of talk about it a little bit. And then the attending would go into a different room. The patient would be there, who was not part of the first part, would be there, and they would do an interview. And the purpose of that varied depending on kind of what the concerns were that the resident had and what they were trying to kind of get over and what hump they had to get over. And then we'd sort of debrief as a group afterwards. So one of the ones that I was involved in, one of our residents came in, basically was presenting a woman in her mid-40s, who was, basically what he said was, she's now telling me she's suicidal. I know you've been teaching us all this stuff about it. I keep trying to work through some of those things with her. It just doesn't seem to be going anywhere, and I'm concerned. So I get put into this room. This 40-something woman is there. We start interacting. I'm talking with her a little bit about her experience. And just to give you a sense of her experience, if you can imagine every awful thing that could possibly ever have happened in the life of a 40-something-year-old woman, it has happened to this woman 50 times over, it seems. It's one of those jaw-dropping experiences where you just sit there and realize that people are incredibly resilient to have dealt with so many things in their life. And so here she's describing all these things. She's sad, she's tearful, she's despondent, she's talking about it's not worth living anymore and all this other kind of stuff. So we're having a conversation a little bit about, what do you do when these things come up? What she tells me is that she's involved in a DBT group at another place nearby. And they're trying to help her with skills around these things, but she has a list of like 75 different things to do to help her make her happy. So I said, that's interesting. Well, what do you do with it? She goes, I don't do anything with it because I don't know where to start. There's 75 things on this list. I have no idea. And she goes, most of them don't even apply to me. So I don't even have the list anymore. Now, this is not a knock against DBT. DBT is quite good. It's just for her, that piece of it wasn't working really well. So I said, would it be possible if the two of us could work together and try to develop a plan that might be more targeted to you, that utilizes things that you've done in the past so that you can see that you have the ability to do it? And here she is, tearful, despondent, again, saying there's no reason to live anymore, and says, fine, whatever. Now, I don't think she's terribly engaged in the process when we start this. But what happens is quickly over time, as we start working through this safety planning process, she starts to realize that she has a ton of resources that have worked in the past, even for a brief time, have worked in the past to get her through those difficult times. And at the end of about 20 minutes of going through all of this, she's got a smile on her face. And she's saying, you know, I had no idea I had all these skills. I didn't realize I was capable of doing all these things. I didn't give her any of the ideas. She came up with all of this stuff on her own. And so she feels empowered to be able to take care of herself. She feels like, even though she recognizes, listen, I'm still going to feel suicidal from time to time, but at least when that happens, I know that I can take care of myself. I can find a way to get through it. Because getting through it's important, because otherwise the therapy side of it, in terms of getting through what has led to the suicidal thoughts, how do we address those kinds of things? That stuff can't happen if they don't live. So we have to get them through those moments. And she felt empowered and was able to take care of herself. I remember seeing her in the waiting room 6 months later. She had a smile on her face. I've been using this stuff. It's been really helpful, and my therapy is going really well. So in that 20 minutes of her feeling like, I don't know, whatever, sure, we can do this, until it was done, you know, there's huge change in terms of just her commitment to getting better. So who develops it? It's developed by you as the clinician and the person that you're working with. And who do we want to do this with? Well, in this particular case, we're talking about individuals who've made suicide attempts, who are at risk for suicide because of suicidal ideation, or it could be a whole host of other things. And my guess is, if you pay attention to what we're talking about here, you can certainly imagine other instances and avenues by which you could utilize something like a safety plan. I see some application in addiction and stuff like that. We haven't really tested it in that environment, but there's certainly some other application, as you can imagine. So who's it good for? Who's it not good for? As I said before, you could start this at any point during treatment. You can modify it at any point during treatment. We'll talk about that later. The people that it's not terribly helpful for would be those who are at eminent risk. So, you know, if you're interviewing somebody or you're having a conversation with somebody who's in your office or via telehealth these days, which is even more complicated when it comes to this, you know, if you're doing something like that and you just, this person needs to be hospitalized. Like, I am concerned that if this conversation ends and we don't do anything to protect their safety, that they may not live. That's not somebody we need to develop a safety plan with. We need to help get them to a place where they're safer at that moment. Now, the hope is, and for those of you guys that work in inpatient settings, you know, this is a phenomenal tool to give people at discharge, to work with them before they get discharged from the hospital, such that once they get discharged, they have their safety plan with them. So we don't want to do it when they're at imminent risk and needing to get into the hospital. What we want to do is, once they've settled a little bit in the hospital, is to develop the safety plan for discharge. The other group that it doesn't work terribly well with is individuals with profound cognitive impairment. Some folks at the state and I have been working a little bit on developing a modified version of this same format, but for kids with autism. The differences really are that most of the prompts for them on their safety plan tend to be pictures as opposed to words and stuff like that, but it helps them kind of remember, who do I talk to, and so on. So we haven't tested it, so I don't know how well it works. Anecdotally, some folks have been using it and saying that it's working pretty well. We just simply don't have the data on it. If you're working with youth, the last thing to be thinking about is, you know, you develop this plan. I always say this: develop the plan with the kid by themselves, but you can't send them home with the safety plan without having a conversation with their parents, because obviously if we're doing the safety plan, we're concerned enough about risk for them that we probably need to engage some sort of caretaker. But I usually then review it with that individual before they go home, so they have a chance to ask questions, to make sure they understand it, how to utilize it, etc. But I always do it with the kid first, because typically what happens if you bring, stereotypically, you bring mom into the room, you know, and you got this 14-year-old boy who you're trying to fill the safety plan out with, you know, and you start going through it and you say, you know, can you give me an example of some of, you know, X, Y, or Z? The person that tends to answer the questions is mom. Well, then mom's basically creating the safety plan for the kid. The problem is that the kid didn't create their own safety plan and may then not utilize what we do, and they're the ones that need to use it. So how's it done? We sit side by side. It's a very problem-solving kind of approach to it. You can do it on paper and pencil. When we do this one here this after or later on today, I've already created a template, if you will, like as a Word document on my computer. And so as Lauren and I go through this, I'm going to be just sort of filling it out that way. I'll then share my screen from time to time so you guys can see what I have written down already. You can do it that way. You can do it in paper and pencil. There are apps out there. One is called Safety Net, which is through the iTunes platform. Android is Safety Plan. The icon looks like actually what you see on the screen there, that green plus sign. But there are several others that are actually using the exact same format for this particular module. The key, of course, is that whatever way we do it, we want to make sure that the person who is at risk for suicide has some ability to take it home with them. If they do it in the app, that's fine. You just want to make sure you have a record of it for yourself. So you're probably, putting it into a chart, you're writing it down, whatever version you're keeping it. Make sure you have a copy of it as well. But if they want to put it in their app because that's the way they're going to be able to remember it, that's fine too. So this is just a sample of what it looks like. I sent Jen a copy of something that's basically the same thing. So that's available for you guys to have. This is the paper pencil version of it. Again, you can always kind of work on it that way. Once you've done this enough times, you kind of know the different steps. You can sort of do it on the fly, write it. I've used actually with that woman that I was giving you the example of in the mirror case that we did. I didn't have any paper. I didn't have anything with me in that room. And so when we agreed that I had no idea that was what we were going to do when we were in there. But when it came to the point where this might be the most effective thing that we could be doing right now, I turned to the camera and asked for somebody to bring me a sheet of paper and a pencil. And so they did, and I just did it on the fly. So you'll be able to do those kinds of things once you've practiced it a bit. So let's get through the meat and potatoes. Like, what is a safety plan? What are the different steps? There are 6 steps in developing an effective safety plan. The meat and potatoes are 2 through 5. So 1 is really the setup. 6 is really, again, in the preparation phase. 6 is sort of the last thing we need to think about as we are developing the plan. But 2, 3, 4, and 5 are the major things that people can do to take care of themselves. So step 1 is basically, when do I need my safety plan? So step 1 is, how do I know, like, what happens before I start having thoughts of suicide? So what are the things that are going on that might lead me to feel like, I may not want to live anymore. I may want to do something about that, those kinds of things. What are the things that tell you that you may start to feel suicidal? There's always sort of prompts and triggers, if you will, that people experience. And for individuals that have thoughts of suicide frequently, there are similar things that tend to emerge again and again and again. Now, I don't say, these are just examples. I don't ever say, do you ever feel like a failure? Like, never, ever, ever do I say a thing. I might say, are there certain thoughts that might go through your mind or something like that sort of pop up before you then start thinking about suicide? Are there images that you start thinking about or you sort of see in your mind before you start thinking about suicide? Do you find your mind kind of focused or doing something a little bit differently? What about your mood? Do you feel a certain way before you start having thoughts of suicide? And then finally, behaviors. Are there certain things that you do or that come up that might happen before you start feeling suicidal? I had a patient once who was depressed. I think was just trying to acknowledge the fact that she was depressed. And from time to time, she would just start having these crying spells in the middle of just seemingly out of the blue for her. And that would prompt her to feel suicidal, largely because she described it as sort of the embarrassment of it. I don't know why I'm feeling like this. I don't know. I don't want everyone to see it. I know that I'm sad sometimes, but I don't need everybody to see it. And the embarrassment of it was leading her to feel suicidal from time to time. So it's something like, so sometimes it could be something like that, where it's sort of a crying spell. It could be, people know, like, if I'm not feeling great and I put myself in a room by myself, my head's just going to start swirling. And the next thing you know, I just don't want to live anymore. So the isolation piece could be the thing that prompts it. So step 1 is, when do I need my safety plan? Step 2, which is really, like, as I said, the beginning of the meat and potatoes. Step 2 is, what can you do by yourself, for yourself, to take care of yourself during these times when you're feeling down, depressed, and suicidal? Now, the interesting thing on this is that if you are interacting with somebody who is now telling you they're having thoughts of suicide, I can promise you 99.9% of the time, this is not the first time they have had a thought of suicide. This may be the first time that they feel safe and comfortable enough expressing that to somebody. And it certainly might be the first time they feel safe and comfortable expressing it to somebody in the behavioral health field, for example. What that means is they've gotten through these times before, therefore they have used some strategies to get through this before. So what have you done in the past? When you have felt suicidal before, what have you done in the past that helped you get through those moments? That's what we're trying to address right here. It doesn't have to be, it got you through this moment and it made you feel fantastic, and you felt fantastic until today when now you're telling me you're not feeling fantastic. No, no, no. It's okay if it helps them out, even if it's for a brief period of time. You have to remember the whole point of this intervention is to prevent somebody from engaging in a suicidal behavior at that time. Therefore, if it only works for 15 or 20 minutes, fine by me. Because in 15 or 20 minutes, some other things could happen that shift the trajectory of what's going to happen that day. And if that shifts it in a direction where they are going to move forward and continue to live, then we have done our job. So what can you do on your own, by yourself, to take care of yourself if these thoughts emerge? And again, I don't ever say, could you do this? Could you do that? These are just examples. Sometimes people are like, oh, I've had these thoughts before. What did you do? I didn't do anything. It just went away. I'm giving Lauren like secrets here because like these are the difficult patients. Oh, nothing. It just went away. So during that time, when it went away, what were you doing? I don't know. I mean, I was kind of laying in bed and I said, okay, well, did you do that the whole time? Well, I mean, eventually I guess I got on my computer and, well, okay, what did you do on your computer? Well, I got on the internet and was reading like news stories and stuff like that. Okay, so you were searching the internet for news stories. Was that helpful? Got my mind off of it. I guess I stopped really thinking about wanting to die when I did that. Did you find yourself feeling better? Yeah, actually, I guess I did. Okay, so there you go. You suddenly now have something on their list, which is, you know, search the internet for stories that make you feel good or something like that. What else have you done? What else have you done? I always keep asking, well, what else have you done? Because typically you'll have people come up with more than one thing. In fact, this woman that I was talking with, she had a couple of things that she could come up with immediately. And then I kept asking, well, what else have you done? And she goes, well, actually I've done this before. Okay, we write that down. Well, what else have you done? That list went on for like 7 or 8 things. Because eventually she started to realize I've actually done quite a bit of stuff to take care of myself. And this was actually the turning point in her mood. You could see it when she started putting these things down. She realized, wait a minute, I've actually done some of these things and they've been helpful for me. Now, the other piece of all of this is that we need to also recognize that sometimes the strategies that are on the list can't be used all of the time. So, you know, I always use this example in Philadelphia because, you know, it's an inner city kind of issue sometimes. So there's some areas of Philadelphia where, like, if you were to say, I go for a walk. When I'm feeling suicidal, if I go outside and I go for a walk, that's helpful. Well, if you happen to live in a couple of areas of the city where going out for a walk at 2 o'clock in the morning, because that's when you feel suicidal, actually wouldn't be terribly helpful, we need to have a backup plan. So it's you know, all right, well, if this is going on, what else could you do? So going for a walk, all right, are there instances where you wouldn't be able to do that? Well, I'm in the middle of class. I can't really get up out of class and go for a walk. Well, what else could you do during that time? Now, we don't sit there and not write go for a walk. We always write go for a walk. But when we say, okay, well, what might get in the way of doing that? Okay, well, this might, okay, well, what else could you do in that situation? Well, I guess I could do this. So we write that down. Okay, well, what else could you do? You know, we don't have to get into high-level military training kind of perspective where it's like, what's the contingency plan to the 5th contingency plan? We're not there. It's really, though, in the most obvious things that can't be done. All right, going for a walk. Well, that's not going to work at 2 o'clock in the morning. What else could you do? I could listen to music. All right. Well, tell me about that. How does that work for you? I just crank it up really loud and just, you know, really, I let my body connect to it and say, okay, well, at 2 o'clock in the morning, crank it up really loud. How's that going to go? That's not going to go over really well. Okay. Do you have headphones? No. All right. What else could you do? I pet my dog. Okay. Could you do that at 2 o'clock in the morning? Yeah, my dog usually sleeps in my room. Okay. What else could you do? So even though we found the answer or an answer, what else could you do? All right. How likely would you be able to use these things in a crisis? What might get in the way? These are the things we were just talking about. So step one, when do I need my safety plan? Step two, what can I do to help myself? Step three is distraction. And people often say distraction's not helpful. It's not therapeutic. Like, what in the world is distraction? Like, how can that be at all helpful? And so I'm going to give you an example of a teenage boy that I was working with that I will probably use this example of distraction for as long as I continue to do this kind of training, because unless something else comes up that's better than this will completely nail home why we do this. So 17-year-old boy struggling with thoughts of suicide from time to time, developed a safety plan. He came up with it. He felt pretty confident in his ability to use all this kind of stuff. One evening becomes suicidal. Starts working on what are the things that he's pulled out a safety plan. He starts working on the things in step two that he can do to take care of himself. What he's discovering is those things aren't working. So what do? You go to step three. Step three is hang out with, on there he had like hang out with a friend. Now at this stage, it's about distraction. This is not about go talk to somebody about how you're feeling. This is literally just get yourself around other people, around other places, those kinds of things, which I do fully recognize in the middle of a global pandemic. This is the step that is the most complicated and difficult one of all to do. But we can modify these things just like we're doing right now. A year ago, I'd be out there with you guys in Beaver County, someplace, and we'd be doing this live. We're not doing it like that right now. We can also have social interactions this way. It's maybe not the most satisfying. It may not be the most helpful. And there may be other ways to interact with people in person too, that we could still utilize even in the midst of a pandemic. The point is, who do we get ourselves around? Where can we be that we're around people? We do not want people that are suicidal isolating themselves from others. And so step three is about distraction. And on this particular kid's thing, it was like, go hang out with, I'm gonna just say Billy. I don't remember what the kid's name was. Go hang out with Billy. So he texts his friend Billy, he says, what are you doing? Billy says, I'm thinking about playing some video games. You want to play? And he says, yeah, do you mind if I come over, as opposed to, let's get on the system like at your place and me at my place and we'll do it that way. He was like, yeah, sure, come on over. So he goes over. Now, admittedly, my patient is thinking, he was in a pretty bad spot. Didn't necessarily have much hope that this was going to be helpful, and was like, fine, he just will go over. So goes over, and he comes to tell me after the fact, he says, I was just kind of going through the motions. I was playing the games. I don't think I was enjoying it. I was just kind of going through the motions. And so he's realizing this doesn't feel like it's very helpful either, until Billy says, what are you doing this weekend? And he says, I don't know. Now, what he thought when he said, I don't know, is I'm going to be dead this weekend. This is what he reports to me later. So obviously he lives through this experience. So he tells me after the fact, he says, my thought when he said that was, I'm going to be dead, but I don't want to burden my friend by telling him that. So I'm going to tell him I don't know. So Billy says, what are you going to do this weekend? He says, I don't know. He then says, well, so-and-so is having a party. You should come. He's like, yeah, okay, maybe. And again, his thought is, I'm going to be dead. It doesn't really matter, but yeah, whatever. And then Billy says to him, I hear Susie's going to be there, and I hear she might like you. And so my patient, 17-year-old boy, says, maybe I can die on Friday, or maybe I can die on Monday. So his whole thought process was derailed by the fact that maybe going to this party might be enjoyable for me. Maybe there might be something worth living at this party. Maybe that will be okay. So in the midst of this step three distraction for him, he found a reason to live beyond that day. It didn't have to be forever, but beyond that day, found a reason to live. Said he felt a little bit better after that. And so I saw him the following week, and of course I'm like, what happened? So, well, I got a new girlfriend. Okay. So, we're not trying to solve problems through creating dating mechanisms and stuff like that. But the point is, a simple distraction in this case, what happens with distraction is that we never know what potentially could happen in those moments that could really change the trajectory of what's about to happen. In this particular case, something came up that he was not expecting. He thought, that's interesting. Maybe that's worth going to. All right, I'll hang out for a little bit longer. And if it doesn't work out, well, I'll just die later. That's fine. turned out that it worked out. And here he was in my office and we were having this conversation. So that's step 3, right? Who do you enjoy socializing with? Who can help take your mind off the problems, at least for a little while? Sometimes it's going places. Are there places where people can hang out and you're just going to be around other people? Who are the other people you can be around? We used to, it's sort of like, what's the coffee shop or the diner or something like that people are constantly going in and out of that, if you hang out there, you just want to be around people and not be by yourself. So step 1, when do I need my safety plan? Step 2, what can I do to help myself? Step 3 is distraction. Step 4 is those other things haven't worked yet. So step 4 is who can I talk to that maybe I can talk to a little bit about how I've been feeling. Now, you don't have to say, I'm going to call somebody on the phone and tell them I want to die. In fact, it can be somebody that you can say, listen, I'm having a really bad day. Who could you talk to about that? So who are the family members, the friends that you can have this conversation with? How willing would you be to contact those individuals? From a youth perspective, I think we all know if you work with kids, if you say, who can you talk to? The first person they're going to list is some other kid. Now, to some degree, there's a part of that that's slightly okay. If you're having a bad day, talking to a friend, perfectly fine. If you are in the midst of managing a suicidal crisis and you are on step 4 of your safety plan because you can't figure out how to take care of yourself, being around people in distraction isn't working, and you're still feeling suicidal and it's increasing, the last thing we need you doing is calling up a friend of yours and telling them essentially that you want to die. It's the one thing that I instruct kids that they can't do in this process. And the reason for that is it's not fair to both the patient and the other kid who have to experience that conversation, because that relationship is going to change forever. I'll give you an example. So if you can imagine 2, 15-year-olds, if you will, and we use Jen as an example here. So let's say Jen and I are in the same class in school, and I'm feeling kind of down in the dumps and not doing really well and starting to feel suicidal or something like that. But Jen, I've seen, has been really helpful in talking to other people. She's nice to me in class, and somebody that maybe I could talk to. And so, I called Jen up, and she's 15. And so what she does is, like, she's thinking, you have to remember, interpersonal development, huge part of what's going on right now. And so Jen's like going, okay, well, maybe I can be helpful. And so we have a conversation. What happens at the end of that conversation is, I feel better. Jen feels better. Why? Because she's been helpful to me in some way. And, that conversation ends and everybody's feeling a little bit better. And that sort of helped. What happens is I've learned now that I can talk to Jen, and that works. So the next time I feel a bit suicidal, I call Jen on the phone. She's like, oh, okay. And then we talk. And at some point in time, I really tell her how I'm feeling, which is, I'm not just thinking about this from time to time, but I've actually thought about what I would do, how I would do this. And I'm thinking I might do it now. And, but you can't tell anybody. Remember the secret that everybody's not allowed to have? So they share this secret. She says, follow, fine, I won't tell anyone. Why? Because she's 15 and this is what she thinks is the right thing to do. She's afraid if she tells my parents, what are they going to do? And I say, oh, listen, my parents are going to freak out. You can't tell them. You can't tell somebody at school, blah, blah, blah. So she doesn't tell anybody. What happens then is, over time, I call her, she helps me, I feel better, she feels better, and it continues. And eventually what happens is I call her, and Jen has this suddenly realization that she realizes that I don't know how helpful I'm actually being. He keeps calling me. And as much as I want to be helpful, I'm clearly maybe not being as helpful as I thought I was, because he keeps calling. Like, I don't know what to do. And I'm not really sure. Maybe she's been having a conversation with some friends of hers about, what do I do in this situation? And he keeps calling me. I don't know what to do. And so what happens in that moment is that Jen doesn't answer her phone. And then who is left feeling abandoned, isolated, alone, and worse than they were before? Yeah, that would be me. But whose fault is it that I feel that way? Whoever stuck Jen on my safety plan. Why? Because she doesn't have the capability of addressing those kinds of things, right? We want to make sure that, yeah, if I'm having a bad day, I'm not suicidal, but just a crappy day, like, talking to Jen would be fantastic as teenagers, But we want to make sure that kids also have adults in their life they can go to, because if they're actually thinking about suicide, they don't have the right to call their friend when they're standing on the roof of the building. Because like I said, that relationship changes forever. If they don't jump, that other kid still knows that's where you were standing. And if they do, that other kid is left having to deal with that. It's not fair to either of those individuals. And so I always encourage them, bring adults into the conversation. And again, it doesn't have to be mom or dad. You know, it could be other family member. It could be somebody at school. It could be somebody at church. It could be somebody on, an adult like coach on a sports team. It doesn't matter. It's who could you talk to about having a bad day? Because even if you're having thoughts of suicide, you can always start the conversation with one of those folks. I'm just having a really bad day. Can we talk? Like, who would be open to that conversation and bringing somebody like that into the fold? So step 4 is, who can we contact? Family and friends, in terms of helping us, through these times. Step 1, when do I need my safety plan? Step 2, what can I do to help myself? Step 3 is distraction. Step 4 is, who can I talk to? Step 5 is, guess what? None of those things are working. Now you get to call me. In other words, as their behavioral health provider, now they get to call you. They've done everything else to take care of themselves. Nothing seems to be working. At this stage, it's call you or go someplace that can make sure that they're safe, because our job is to ensure that we can do those things for them. We have that responsibility. I will tell you, I've been developing safety plans with people for 13, 14 years at this stage. I have only had 2 people ever call me, because all of the others have found that steps 2, 3, or 4 have worked for them. Usually step 2 has worked for them well enough that it has gotten them through those moments. We have a conversation later, but they never had to call me to say, hey, I'm suicidal, can we talk? Now, this isn't me saying, listen, don't call me. If you're suicidal, don't call me. But we also don't want to encourage people that that's the first step in the process. This is why we are step 5, not step 1. We are step 5. Do all these other things for yourself. Empower them to take care of themselves. If none of those things work, then yeah, you better call me. Let's do that. So contacting the professionals, the agencies. So who do we stick on there? Okay, you can put myself on there. Who else can you talk to? All right, well, there's a local crisis center. I can call them. I can call the National Suicide Prevention Lifeline. There's an urgent care center I can go to. There's an emergency department that I can go to. I can call 911, all these various things. And people often say, oh, no one's going to call 911 for that. I'll say this now, like this is the old way of thinking about it. No one's going to call 911 for that. Well, people call 911 for ridiculous reasons. And in about a year and a half, you won't be calling 911 for it anyway. You'll be calling a different number for it that will be associated with the lifeline at that point in time. But the point is, and hopefully in a couple of years' time, people will know that that's the right number to call. But the point is, call somebody who knows what they're doing, who can support you and help you and make sure that you're safe. Once they've gotten to step 5, they should be fine. I shouldn't say fine, but they should be taken care of. Okay, so that's where you get to step 5. The last thing in terms of these 6 steps is reducing the potential for lethal means. Now, lethal means restrictions, a whole nother conversation. We're not going to get into all that stuff today. But it is incredibly important to have a conversation while you are developing the plan. Not, this isn't step 6, like they made the phone call, now I get into my lethal means discussion. No. This is at the beginning. What have they considered doing to end their own life? Do they have access to a gun? If they have access to a gun and we're developing safety plans for them, there needs to be a conversation about how can we reduce access to that gun, whether that be get it out of the house, which is evidence-based, the most effective way of dealing with it, or how can we secure it and keep it safe in a way that this individual does not have access to the gun and the ammunition and can fire that weapon, because if they can, we know people die. So what are the access to lethal means? What are the things that they're thinking about? We don't have to say, oh, do you have this? Do you have this? Do you have this? We don't have to go through all the things they could do. What have they been thinking about doing? And we always ask, do they have a gun in their house? So we get to those kinds of issues. If it's a low lethality kind of thing, and overdosing on medication isn't always a low lethality kind of thing, but there are things we can get rid of. I'm not going to ask all of you guys to raise your virtual hands here, but if you really think about it, how many people here have, medications in their house that they have no need for anymore. They have excessive amounts of all kinds of stuff laying around that either it's an old medication that they just didn't dispose of the last bit that was there, or, I'm as guilty as the next person. I've gone to Costco and bought my 500 count of ibuprofen because, I don't even remember what happened, but, I probably had some pain that I thought this is going to last like apparently the rest of my life because I need 500 of them. But you buy that. Why? Because it costs like 13 bucks for 500, or I could go to Target and I could get 100 for 12 bucks. Like I could get 400 more pills for $1 more. Like economically, this makes sense. From a suicide prevention standpoint, not a good idea. So if we're working with folks that have a lot of risk for suicide, how do we get rid of the things in our house that they really just don't need to have any access to at all? So if there's excessive medication, how can we dispose of that? If you have things and you're not sure how to dispose of them effectively, you can take them. Most emergency departments will take those kinds of things. Many doctors' offices will take those kinds of things because they have methods of disposing medications. Certainly the hospitals do. They'll take those kinds of things from you so that you can dispose of them properly. But if it's low lethality or lower lethality, how do we do that? Higher lethality is securing it, limiting it, getting it away. That's the access to the guns and so forth that we were talking about. And finally, the very, very last thing on our sheet is a statement. It says, the one thing that is most important to me and worth living for is, have them fill the last bit of that sentence in. Why? Because we want them to realize that they are meaningful, important, worthwhile, and there is something in life worth living for. So in the midst of developing this plan, not only do they feel good, that they have the resources, because these are all strategies they came up with. I didn't come up with any of them on my own. They came up with them on their own. These are all strategies that they've used that have gotten them through difficult moments. And there is something in their life worth living for. People get done with this intervention and most of the time feel pretty good about themselves. So just the last little practical bit, and we'll stop and see what some of our questions were in this first half here. So, we want to think about implementation. What might get in the way of using your plan? Where are you going to keep it? How's it going to work? If you write it down on a sheet of paper, we're well beyond the years where people would fold up a sheet of paper and stick it in their back pocket and carry it around, or even, women, folding it up and stick it in your purse and stuff like that. Like it's an antiquated way of handling this. If that's what they want to do, that's fine. The likelihood of them losing it is much greater. That's why we have our own copy, so that we can give them another copy when they lose it. How else can they have this and have access to it whenever they might need it? If they don't want to download the app, but they have a phone and they got a smartphone, they can take a picture of it, do that. You have a copy for your record, they have a picture of it, and they can use it that way. And people have found that to be really, really effective. What might get in the way of using your safety plan? What are some of those barriers? How can we work through some of those kinds of issues? And we want to review it periodically. If you develop a safety plan with somebody, and they come back a couple of weeks later, so, we developed that safety plan a couple of weeks ago. Have you had any opportunity or need to use it? No. Okay, fine. Come back the next time. Tell me about the safety plan. Have you had any need to use it? Well, yeah, I did. Okay, well, tell me about it. How did that go? Well, it worked really well. I was really struggling to figure out some stuff for myself. I couldn't find any place to go because it was really late at night. And so getting myself around other people, like I tried to go hang out with my boyfriend or whatever. And that just, he wasn't available. That didn't work. So I started calling people, and I called my Uncle Larry, and he was drunk. So that really wasn't helpful. He was on my list, but I found a neighbor or somebody that I could talk to, and that was really helpful. So guess what? We're going to take Uncle Larry off, and we're going to put the neighbor on. It's not a static document. You can revise it. There's a couple of great resources that exist out there. There's a Zero Suicide Initiative or Institute or Academy. If you look up Zero Suicide in Google, you'll find it. But the point is, they have a website, and on that website, they actually have a sample of somebody doing a safety plan, worth looking at. These are resources that I encourage everybody to make sure they have on hand that they could share with people. So you have the National Suicide Prevention Lifeline, 1-800-273-8255. Right now, we're doing a great job, I think, in Pennsylvania to be able to answer those calls that are coming through. So for those of you guys out in Beaver County, if you were to call that number, There are some wonderful folks over in Butler County who will be answering that call for you guys. And if they are busy, and there's a ton of them over there, so likely it is that they're not busy. If they are busy, we've got backup people answering the phone in other parts of the state, so that you have somebody in Pennsylvania answering your call who is aware of the resources, who can help you, guide you to resources and supports that you need. And then finally, some people prefer to text as opposed to call. So there's a crisis text line, which is 741-741. And if you text PA at the beginning of that, then we get a little bit of like metadata to it. We don't get the actual text messages that are going back and forth, but we get, you actually get a little bit of information on like area code, and the first 3 numbers of their phone number would tell you kind of where they're calling from. So you get some geography, and occasionally you can get demographic data if that kind of stuff is collected too. But again, it's not identifiable by any stretch of the imagination. You can really text anything to start that conversation. But again, if you're in Pennsylvania, texting PA is helpful for us to understand how it's being used and how to market it better. If you want to learn some more information about preventing not just youth suicide, but suicide as a whole, preventsuicidepalearning.com. I think you can get there through pspalearning.com. It's a free online like resource of courses and materials and stuff like that. You're welcome to go on there and pick out information there. And this is my contact information. I'm going to leave that up just for a second. But that's the end of this portion. So we'll get to the questions, which I'm not going to be able to see while this is sitting up on the screen. So I'm going to hold on this for just a second, and then I'll stop sharing my screen and we can get to the questions. But Alicia, are you taking a look at the questions? Are there things up there that we want to start talking about before I pull this off?
Yes, there are a few questions in the chat box for you, and I can pull those up.
Okay, I'm going to stop my share. I can always share this information later with folks. All right.
All right. One of the first questions was, what is the app? And the second part of that question is, will this PowerPoint be shared?
The app, good question, because it used to be called Safe. Well, all right, so I got an iPhone. So with iTunes, it used to be called Safety Plan. There's another one, let's see, there's an app called Safety Plan. It's a white icon with a green plus sign. Like that's the one that's directly related to these 6 steps. There are some other ones that have started to incorporate those steps into them, but that's the one that I would be going towards. And then the other thing, sharing the slides, I'd be happy to do that. I can send you guys that information. Safety Net with green plus, thank you.
Wonderful, thank you.
Yeah, if you send me the PowerPoint, I can send that out to everyone. Thanks, Matt.
Yep, sounds good. If you think about it, just send me an email right now, Jen, and I'll make sure to attach it to your email.
All right, great.
Thank you, guys. The next question is, should you discourage the reason for living being a boyfriend or girlfriend in case of a breakup?
I think we want to look, I wouldn't discourage it, but I would encourage additional reasons for living beyond that. It's one thing to say, I have a meaningful person in my life. We don't want to say, well, listen, it's just a boyfriend or girlfriend. Until you stick a ring on that finger, that one doesn't count. Like, that's not, like, we don't want that to be the conversation. In the same vein, though, there are plenty of people who have very, very meaningful relationships without the ring on the finger. So we don't want to take that option out of play. But we do want to see what other, like, that's a great option, or that's a great reason to live. Let's talk about some other things. What else do you have for you? You know, and have them enter a few other things on there too.
Okay, and the next question is, I'd like to know if talking about removing lethal potential such as medication. My question is, if an adolescent, do we discuss this issue with a parent and or guardian to assist in removing lethal potential? And I said, thank you. And that's from Robin Barletto.
Yeah, absolutely. So this is, as I said before, if we're working with kids, I think it's important to create the original plan with the kid. Why? Because mom usually comes in and takes over, and it's not very helpful when mom creates the plan herself, not because she doesn't come up with a good plan, but because she came up with it, the kid isn't going to necessarily want to use it. But when we bring the parent in for a conversation to review the plan with them, Step 6, I stick on that for a little while because the kids might be like, yeah, I don't think we have any guns in our house and stuff like that. You know, the parents usually know the answer to the question, you know, and so it's, you know, how do we have those conversations? Because sometimes they may have a gun at the house, the kid may not even know about it, which is highly, highly unlikely. I always remind people, it's sort of like right before the holidays when you were a kid, how many people snooped around when your parents were gone, and kind of, I remind people when it comes to like kids and trying to figure out like lethal means restriction, we always talk about what's the likelihood that your kids have been through every single one of the drawers in your house. The answer to that is very, very high. So my point is they usually know where there's something at. So then it's definitely working with the parents on restricting access to that. And I've had a couple instances where parents have said, listen, we're not gonna get the gun out of the house. Like and it never turns into a Second Amendment discussion. I never, ever get into a conversation about who has the right to have a gun and who doesn't, because that becomes completely unhelpful and ends up pitting people against each other as opposed to teaming up together. It's not about that. It's about how can we keep this individual safe if a crisis were to emerge. The data is overwhelming. If somebody becomes suicidal and they have access to a gun in their home, the likelihood of dying is significantly greater than any other combination of those kinds of things put together. So you definitely have a conversation with the parent. The medication thing, talking with parents about that too, because again, kids probably know where most of the medications are in the house. I had a parent once who was a nurse who had a kid who was talking about overdosing on medications. And several of the other kids, there was like 5 kids in this family. And so some of the other kids and one of the parents at least were taking a reasonable number of medications. So they had a lot of medications in their house. And I suggested to them, I said, what if you consider getting a safe that you can put all this stuff in? And the mom, who again was a nurse, looked at me like, then I'll feel like a nurse in my own home. I'll have to go in there and dispense medicine to everybody and stuff. This is where therapeutic silence is brilliant. I said nothing. I just looked at her, and then eventually it dawned on her that her options were find a way to secure all this stuff or potentially prepare for a funeral. You don't have to say that to them. They eventually figure that stuff out. So she went out and she got this safe. They put all the medication in. And guess what? The kids had zero access to going in there and getting the medication out. But you definitely want to go over the lethal means stuff with the parents, because the kids, sometimes they don't tell you everything. Sometimes they don't know everything. But part of what we're trying to do by bringing the parent back in is activating them to utilize their caregiving, attachment-based instincts to take care of their kids. And if it means securing things so their kid can't use those things, then that's what we need to do.
Thank you. The next question is, how do you help people deal with guilt that they are unable to enjoy social supports when they feel so crappy?
Seems like a different question, safety planning. How to deal with, can you read it again?
Sure. How do you help people deal with guilt that they are unable to enjoy social support when they feel so crappy?
That's a tricky one, because I think, some people, again, when they're depressed, they don't want to be around other people. They feel like the thing about it is it tends to be a very cognitive process. What happens is when they get depressed, they think of themselves as, I'm depressed, I can't, oh, Dale's saying he can explain it better over the mic. All right, go ahead and unmute yourself, Dale. Tell us what you were thinking about there, because I think I know what you're saying, but maybe I'm not.
No, yeah, sorry. So I just know with some of my experience, especially with like some of my female clients, typically is where I see this, is when they're trying to distract themselves with their friend group. A lot of times they'll still have those kind of like thoughts or those feelings that are residually there. And then they'll come and they'll talk about how they feel guilty at the fact that like they were trying to be present to their friends, but all they did was feel crappy. And so now it's almost compounded the problem. And so I guess the question was more of like, how do you help them process that guilt? So it's maybe not something that they're so focused on. just because I've seen that, not necessarily with a client that was suicidal, but just one that was like severely depressed. So like if she were to become suicidal, I would know that would be a hurdle for her, is to engage in those social interactions.
Yeah, so that's I would argue there's another intervention that gets employed at that point in time, because oftentimes what happens is it tends to be a cognitive process, right? She gets depressed. I'm just saying she because that's what you were kind of going with. She gets depressed. She then starts feeling terrible about herself. I'm not worthwhile. I'm not important. Nobody likes me. You know, whatever the narrative that happens that gets tied into that self-blame, doubt, all of those things. We say go be around other people. So she goes and hangs out with other people. She's going through the motions, much like that kid probably that I was talking about, going through the motions and just kind of, you know, there, but then feels terrible because she's, you know, her friends are trying to engage her and she's feeling terrible in there. And what she thinks is they see me also as all those things she's thinking about herself, right? So she thinks I'm not worthwhile, I'm, you know, all this kind of stuff. And when she's around them, by her not engaging with them as much as she would like to and be as happy and truly happy with them as she is, she thinks they think bad things about her as well. So that's where the guilt then comes in about the whole thing, right? The trick is it becomes more of a cognitive thing on the other end of it, which is, all right, let's talk about some of those situations where those things happen. What I usually do with folks in that situation is do something like a thought record where it's going to be looking at, let's talk about the things that elicit those feelings for yourself. What do you think other people think about you? Blah, 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 blah. And then eventually what happens is if you work through a thought record, which is, again, different interventions, so I don't want to get into it too much right here. If you get them to start exploring alternatives to what their friends might be thinking about them in those contexts, what you discover is it's possible that the friends aren't thinking that, why is she here? Like, there's not, like, you know, she just seems so depressed. Like, I don't want to spend time with her. All the terrible things that she thinks that about herself that she's projecting onto her friends, she might discover that those are things that they're not actually experiencing at all. In fact, there's actually evidence to suggest that they don't think that about her because they've texted her later or, you know, whatever is going on. The problem is she feels those things about herself. She projects them onto her friends and it ruins her experience with them. Does that make sense?
Absolutely. Thank you. I can also explain, then I also wrote the next question. So if you have questions about it, I can explain it too. There's like a little bit of background to it. Sorry. Okay.
Well, let's do a couple more. And then I want to jump into this sample with Lauren here because I don't know how long it's going to take. I hope it doesn't take us too awfully long. And Lauren, if you don't get too complex, we can probably power through this in 20 minutes or so. But go ahead, Alicia, what else do we have?
Okay, the next question is, should we try to contact and discuss with the adults on what they could do, would do?
To the people that are listed on our contact list of supports? That's probably what that's for.
Yeah. Yes, I'm the one who wrote that question.
Yeah. So if I put you on my list, should somebody be in touch with you so that you know that you're on my list? And well, what you can do to be helpful?
Yeah, exactly. My question is more of like, if we're not going to contact a parent or they're uncomfortable with talking about this with their parent at a time, making sure that like I can see the same thing. Like they contact this adult. This adult is out of the blue, right? That they're getting this call and they're getting talked about. Not all adults are equipped to handle that situation. And so my question is if they're going to put that person on the list, should we like talk about, all right, when are you going to talk to them? How are you going to talk to them about this? Should we do that in the conversation? I know I've had a professor talk about how he'll bring in people, he'll talk about this is what's going on. This is what we're kind of thinking about. Will you do this? Because sometimes they may not be willing to do it because they're uncomfortable with whatever reason. Sorry.
Yeah, I think there's two ways of thinking about it. The one is if it's somebody who is a reasonable person to have a conversation with. And again, as we review this, if you're talking about a kid and you're talking about an adult that they could talk to and their parents are then a part of the discussion, you know, the parents might be able to say, well, should I talk to this person? Should, you know, like that kind of stuff. I think if there's an opportunity to do that, I think that's okay. We don't want to scare the people on the list away either. And the truth is, we're not saying, I got a call, I'm using Hannah as an example. Sorry, I know Hannah from our other stuff. So, you know, if I call Hannah on the phone, I don't want to force her into thinking she has to solve my problem. all I need from Hannah is, I'm having a really bad day, can we talk? And let's have that conversation, because that might help out to some degree. The good news is that there's always, should be, more than one person on the list. And there's another step after it anyway. What I have found from doing these safety plans is step 2 tends to be the thing that works most of the time for people. Once they figure out how to take care of themselves, they don't usually get beyond that. Step 3 is sometimes helpful. Step 4, you don't get there very often. And at that stage, you're really just looking for, who can I'm feeling kind of crappy, can we talk? They're not gonna pick somebody, historically, my experience has been, and from what I've heard from others, they don't pick somebody that's going to give them the buck up and deal with it like narrative. That person is not gonna be on their list. It's going to be someone that they think would be open to a conversation. So I don't think they need a whole lot of education. And like I said, the major thing is I also don't want to put pressure, or perceived pressure, if you will, on the person who's going to answer that call, that they somehow have to save that person's life. That is not their job. You know, so if it doesn't work, if they, you know, I call Hannah on the phone and she's having a bad day too or something, and our conversation doesn't go really well, and afterwards I'm not feeling much better, well, I go to step 5. Guess what? Then I'm calling you, Dale, because you're my crisis counselor. So like, I'm calling you because you're on my list. You better handle it, you know, so then we're okay. All right, one more. Do we have, how many more do we have on this? Because we can always do some at the end too.
We have 2 more questions. Do you have time for those?
Let's yeah, quickly, let's see what they are, and then we'll do this other part.
First one, do you suggest the person tells their friend, family that they put them on their safety plan? Why or why not? And how?
Yeah, so that's the discussion I think we just had. I don't necessarily think that somebody needs to be told, hey, by the way, you're on my safety plan. Because again, I don't want someone to feel like it is their responsibility to take care of that person. This is where the kids get into trouble with each other. It's like, you know, they suddenly feel like, oh, I got to take care of this other person. You see this even in college, you know, where you got college students that are like, okay, I won't tell anybody about what's going on, and I'll take care of you and everything's going to be okay. I can give you some really, really, really awful outcomes of how that has played out. So I don't think that you have to tell the people that, because I don't want them to be responsible. Their job is just like, who can I have a conversation with that, you know, if I'm feeling crappy, we've had this conversation before, like, who have you talked to? What's the last one?
And the last one is, how often should safety plans be updated? For example, long-term clients has carried around their plans for years.
Yeah, I think that's a great question. I think it's, you know, it's, you know, probably, I don't think there's a perfect time. Like, I can't say do it, you know, like every 3 months or every 6 months or something like that. But I do think it's worth reviewing. If you have somebody with a safety plan, you should be reviewing that. And the people that do work with folks that are highly suicidal a lot will tell you that at the beginning of every session, there's probably a couple things you're always going to do. One of those things is, did you need to use your safety plan this week? And then let's talk about it. And if the answer is, no, I didn't need to use it, you know, at some point in time you say, okay, well, let's just pull it out and take a look at it again and see, you know, how are you feeling about the people that are on there, the places that you're going to go, the things that you're going to do? Are there any new strategies that you have? Is there anything that isn't working for you? And you make some updates. I certainly think no more than like 3 months before you would do that kind of stuff. But if you're checking in every single time of, did you use it? You often are going to address those things during those check-ins. All right, so Lauren, you ready?
Yes.
Ah, she's back. Okay.
I am.
So I will admit, I've done this in person before. To do this on Zoom is going to be an interesting little challenge for us, because this is not the way that, like in person, it's anyway. The other thing that I will be doing, and again, in person, this is a little bit easier, but as Lauren and I go through this, I have a Word document that I just set up as like a template for the safety plan kind of piece. And as we talk through it, I'm going to put some of her stuff down in that Word document for me. And then I'll stop after a couple sections of it, share it with you guys so you can see kind of what I have down, and then we'll go back and forth. So let me make sure I have my Word document ready to go. There it is. Okay. So, Lauren, what do you want me to call you? Like, Are you going to be some fake person? I mean, yes, you're going to be a fake person, but the point is, should I just call you Lauren?
Yeah, that's fine. Let's make it as easy as possible.
So Lauren, very briefly, why don't you tell the group a little bit about yourself, just so that we all have a sense as to who you are portraying at this stage?
Okay. I am a person who is diagnosed with, we'll say, bipolar disorder, and we'll throw in some borderline personality disorder as well, just to keep things interesting on this Friday. No history of substance use, we'll say that. Some perceived medical issues. Unclear to providers if they're legitimate or not. History of suicide attempt many years ago after conflict with an employer. Need any more than that?
How old are you, Lauren?
I am early 40s.
And who do you live with?
I live with my mother, who is aging and in and out of inpatient medical facilities.
Okay. Out of like general hospital kind of units.
Yes.
Not psychiatric.
Correct.
Got it. Okay. All right. And so from time to time, you feel suicidal.
Yes.
So all right. So Lauren, maybe you could tell me a little bit, when you have these moments when you're feeling suicidal, what have you done in the past that has helped you get through those times?
I like animals. So I have 2 dogs at home. So I take them for a walk or take care of them or play with them or something.
Okay. So you have a couple of strategies perhaps that have worked for you before. I'm wondering would it make sense? Would you be okay with us kind of working together to come up with a plan so that these thoughts of suicide that you have from time to time, if they were to get worse, you would have some strategies that you could use during those times to help you, manage those things? Would that be okay?
Sure.
Okay. So the first part really is the hardest part. So what I'd like us to do is think a little bit about, those instances where these thoughts of suicide have really been at the worst for you. What have been some of the things that happened right before that? So were there certain things going on that led to then you started thinking about suicide?
Yeah. My brother triggers me. I don't know what it is about him, but there's something about him that just triggers me. So anytime I have to talk with him, he's just not supportive. He doesn't help me with mom, and it just makes me triggered.
Okay. So having a conversation with your brother could really kind of elicit some of these thoughts for you.
Mm-hmm.
Okay. Are there other things that have happened in the past that have happened before these suicidal thoughts?
Sometimes if I feel like I don't really have the help I need, or sometimes I get confused easily and I don't feel like I'm doing what I'm supposed to, or like I'm dumb. That can trigger me too.
So sometimes when you feel like you don't have the help that you need, sometimes you have a thought in your mind, I feel dumb. Are there?
Yeah. Like if I can't complete a form and I have to turn it in, it's too much for me sometimes.
Okay. Okay. Anything else that happens for you? Other thoughts that might happen, or behaviors, or mood, or something that might happen before you feel suicidal?
I just get really depressed.
And you find that happens before you start having these thoughts of suicide?
No, it's normally after I've especially with my brother, I start to get real depressed.
Okay.
And then I start thinking about it.
So seems like the depression happens just before the thoughts of suicide. Am I understanding that right?
Yeah, I think so.
Okay. All right. Now, normally I would be writing this stuff. This is an aside, right? I normally be writing this stuff down as we're talking, and I'm kind of going screen back and forth. So real quickly, let me show everybody what I have so far, just so that you can see kind of how I put it together. So here's my safety plan example. You gave me probably about 4 different things that sort of precede these suicidal crises from happening. The first was your brother triggers you, you not feel supported. And what you guys can see from this is I used your words, right? I didn't say she feels this way or whatever, doing this from your perspective. And when we would do this in person, what I would do, like if we were working together, I'd have you fill this out yourself. And so these would be your words, right? So all the things that you put in there, that's what I have up here so far. So we're going to start with that. And then at this stage, I would say, okay, so let's go back to what we had talked about when we first started, which was in these times in the past where you have felt down, depressed, suicidal, what have you been able to do by yourself without anybody else involved to help you get through those times? You mentioned something about your cats before.
My dogs. I don't like cats.
Dogs. Oh, sorry. This is my problem. All right, so tell me about your dogs again. What do you do with them?
I'll take them for a walk or just like take care of them, like give them a bath or maybe give them extra treats or something. Cause I like when them being happy makes me happy.
Okay. Okay. So take your dog for a walk or give a bath or extra treats, something like that. Okay. What other things have you found to be helpful during these times where you felt suicidal in the past that you've done for yourself?
Sometimes I'll call my friends, but
Okay.
I don't like to feel like a burden to them.
Okay. Well, let's hold on that thought for a minute. Okay. We'll talk about reaching out to other people in a second. I'm thinking about you specifically by yourself. What have you been able to do? You know, if you've been feeling really bad, what has helped you before? Other than the dogs.
I got a coloring book recently. I like to color. That's been helpful.
Okay. All right. So color in the coloring book. Anything else that you've found to be helpful in the past?
Listen to music.
Okay. And how do you do that? Do you like turn it up in your car or at home or headphones, or what do you listen? How do you do this?
Normally I'm just at home. I just put it on my phone.
Okay. What kinds of things do you like to listen to?
Anything but country or rap.
Anything but country or rap. Okay. All right. You have a favorite artist that you like?
I do.
Okay. Who's that?
Florence and the Machine.
Florence and the Machine. Okay. All right. So, all right. So this is me breaking aside again.
Yeah.
I would say anything else that you like to do. As you talked about your dogs and you taking dogs for a walk or a bath or extra treats. You talked about the coloring in the coloring book, and you just talked about listening to music. Anything else that you've done in the past that has been helpful?
No, I think that's it.
Okay. So this is sort of my aside here. We got into the music thing. Interestingly, if people go into the music direction, I always ask them, like, you know, tell me a little bit more about it. And the reason is sometimes you get people like into this really dark and dreary kind of stuff. And then, so then it's sort of like, okay, tell me about that. What does that do for you? And it's like, you know, I really get connected to the music and I get really sucked into it. It's not that we're sitting here blaming music for suicide. That's not at all where I'm going. But the point is, we want to make sure that what they're doing isn't actually potentially dragging them down anymore. So we have all those things. I'll go and show that when I get to the next part. So Lauren, we talked a little bit about the things that precede you having these thoughts of suicide. We talked about some things that you can do by yourself that have worked for you in the past. So if we try that and for whatever reason, those things don't work for you, who are some people or where are some places that you could go to kind of get distracted, just to kind of get your mind off of it a little bit?
I used to have a lot more friends, but I guess I left voicemails on their voicemail the last time I was manic, and some of them won't talk to me anymore. This is all obviously pulling from someone real. But I have one friend I just made from a program I go to. I don't know her last name though. Her name's Teresa.
Okay. And are there things that you and Teresa would do to, again, this is not, we're not kind of to the point where we need to talk to Teresa about how you're feeling, but instead, are there things that you and Teresa have done to hang out with each other, or, you know, just something to do to kind of distract you and get your mind off of things?
It's been hard recently to get together with people because of COVID. But the other day she came over and we just sat on my porch and we drank coffee.
Okay. So, maybe we hang out with Teresa, right? And how do you remember how Teresa spells her name? Is there an H or no H? You'd be writing this down anyway.
I don't know.
All right. You'd be writing it down anyway. So it would be whatever way you spell it. What about other people or other places that you could go? Again, it's all about distraction right here. What I'm trying to do is make sure that when you're feeling terrible, you're not just there by yourself.
I don't really have a lot. Like my brother, he's not good. And my mom, I love her, but it's just, I can't rely on her because she's sick and it's hard. But, maybe I could call, like the warm line or something like that.
Okay. It's a good question. Like, where's the warm line going to go? I guess the warm line could go right here, but the warm line's going to then predate, or you're going to skip out of number 4 if you go to the warm line, because if you're in crisis there, they're going to kick you to the crisis number, which is okay. Do you have,
I have friends in Florida. I could at least call them. I wouldn't be able to see them though.
Yeah. Do you do video meetings with anybody? Have you done like FaceTime chats or Zoom or Skype or anything like that with anyone?
I have it. I don't like to do it, but I guess if I needed to, I would. I have to do it with my psychiatrist.
Okay. Are there places near where you live that you like to go and just kind of, there's people there, it's just, just kind of hanging out, like a local coffee shop or diner or anything like that, where there's just people coming in and out all the time?
I'm trying to make this real without being too complicated.
No, I know.
I used to go to the park, but it's cold right now. So I guess weather permitting, I could.
So we could stick park on the list, but again, understanding that if it's really cold outside, that wouldn't be something that you would necessarily do, right? Any other places or people that you could reach out to possibly? Again, it's really about distraction. It's just kind of shooting the breeze with somebody.
I go to psych rehab a couple days a week, but it's scheduled. So, but maybe I could see if I could go a different day if I really needed help.
Right. Okay. Let me ask you this. With your psych rehab program, how does that work? So like, again, this isn't you kind of in the middle of a crisis. So if you called them then, when would you be able to kind of come in? Would you be able to immediately come in for something there? Or is that more of, you could schedule something for the next day perhaps?
It's scheduled, but I think if I really needed some extra support or something to do, that they would let me come.
Okay. All right. Sorry, I got to type this. All right, well, so let's think about this then. If the things that you could do for yourself aren't working really well, some of these distraction things we're talking about aren't working really well, who are some people that perhaps you could talk to? Again, having a really bad day, you don't necessarily have to call them and say you're feeling suicidal, but who are some people that you could talk to, like when you're having a really bad day, that have been reasonably helpful in the past in terms of listening to you and helping you think through some things?
My new friend Teresa, I think she would be helpful.
Okay.
My mom, she's not always super supportive, but sometimes talking to her reminds me that I need to be strong because someone has to take care of her.
Okay. Anyone else that you could reach out to? Again, it doesn't have to be you telling them that you're feeling suicidal unless you feel comfortable doing that, but rather, someone that you can talk to when you've had a bad day in the past and it's just been helpful for you.
Maybe my case manager.
Okay. Anyone else?
No, that's pretty much it.
Okay. So again, if we're working on some of these things by ourselves, so like taking your dog for a walk or the bath or the extra treats or the coloring and the music, those things don't seem to work. You're hanging out with Teresa, shooting the breeze or going to the park, and those things aren't helpful. Now we've kind of amped it up and we're telling Teresa now how we're really feeling. You're talking to your mom, your case manager, or even possibly scheduling a psych rehab support. If none of those things are working, then we're going to get to, now we're kind of at that stage where you're going to call me, okay? Or other people that you work with closely that we know will make sure that you're safe. So I'm going to stick my name down here, okay? And make sure that my phone number is on there. In fact, this will be the way everybody gets to see it again. I'll stick my number on there for you. But there's some other resources. I mean, if none of these things are working, sometimes I tell people this all the time, you may call me. It's possible that you're not going to get in touch with me because, I'm a human being. I could be mowing the lawn. I could be in the restroom. I don't know. And the phone, I want you to leave me a voicemail message. But if that happens, I'll call you back as soon as I possibly can. But I want you to make sure you call something else too. So I'm going to leave you the number for the National Suicide Prevention Lifeline. That would be something else that you could call. Have you ever called that number before?
No.
No? Okay. Do you imagine that you would call a number for somebody that you don't know, but this is a group of people that are really trained on how to help people in crises? Is that a number that you think you might use?
Maybe.
Okay. And then let's think about other resources. What other kind of resources have you had to use in the past? Have you ever gone to the emergency room when you weren't feeling well? Did you have a local crisis center that you might go to? What might you use?
I like the Warm Line, and we have a crisis center too.
Okay. And where's the crisis center located?
It's in Beaver Falls now, I think. Yes, Beaver Falls.
And you know exactly where that is?
Yeah.
Okay. Any other things that you might go to? Again, at this stage, it's really about nothing else seems to work. We want to keep you safe. Who can help you?
That's probably it.
Okay. Well, the only other thing, do you live near a hospital by any chance? Or what's the closest one to you? Maybe that's the question.
It's about 10 minutes away.
Okay. And which hospital is that?
Beaver.
Beaver. Okay. So what I would suggest, if none of these things work, now this is we're never going to get to this point, but we'll use the Beaver emergency department if we absolutely need to. Okay.
Okay.
I feel pretty confident we won't necessarily get there. All right. So the last thing, Lauren, that we just need to talk about, we've got a lot of great resources for you. You have a lot of stuff that you were able to kind of put together and come up with on your own. So you've got a lot of tools for you here. But what we want to make sure is that when you're really struggling, that there are some, that you don't necessarily have things around you that if you feel like ending your own life, you don't have access to some stuff that could really harm you. When you've thought about ending your life in the past, what have you considered using?
One of my attempts, I drank a couple bottles of, I'm no mechanic. It goes in your car. It's antifreeze. And then another one, I took all my medication.
Okay. And can I just, where did you get the antifreeze from? Is that something that you have around your, huh?
I got it at the gas station.
Oh, okay. All right. So that's not something that you typically have around your house, but rather that was something that you went out and got.
Yeah. I wouldn't even know where to put it in my car.
Yeah. Did you go to the gas station and get it for that purpose?
Mm-hmm.
Okay. All right. So, can you imagine seeing yourself doing something like that again?
I hope not. I don't
Okay.
feel like it right now.
Okay. So maybe one of the things that we're going to stick on, because partly what we need to do is kind of try to avoid some certain things. So maybe what I'll stick on your plan is we're going to avoid the gas station. And you'll know what that means, right?
Mm-hmm.
Okay. And then you said you had taken some of your pills before. Tell me a little bit about that.
I just took all of them.
Okay. So what happens if you start feeling, now I know based on what you shared with me before, you take some medications that you probably have to take on a daily basis. And so it's like, we can't just lock those things up for you all the time. Otherwise you won't be taking, medications that you use right now to help you feel better. I wonder if there might be a strategy to think about how to make sure you don't have enough so that if you did take all that you had, you still wouldn't die.
I take an injection now, so I don't have as many medicines lying around.
Okay. And for what you have lying around, what do you have lying around?
I've I give myself a B12 injection. And I have some Valium.
Okay.
And there's another one I can't remember. I think it's Zoloft.
Okay. So let's talk about the Valium for a second. So where do you get the Valium? Is that something that you get prescribed from your psychiatrist?
Mm-hmm.
How much do you get at a time?
30 days.
30 days. And so, Valium is sometimes we call it as a PRN, right? You take it when you need to take it and that kind of stuff. So in a 30-day period, like how many pills do you get?
Did you say in a 30-day period, how many pills do you get or take?
How many do you get?
30.
I actually don't care how many you take. I want to know how many you have on hand.
30. 30.
30. Okay. I would never tell you what I just said a second ago, by the way, but that's for everybody else's knowledge. Like, I want to know how many you have on hand. And so do you take one? And so how do you take that? Do you always take one a day, or do you sometimes go with days with not needing to take it because you're doing okay?
More days than not, I take one every day.
Okay. So at the end of the month, how many pills do you think you typically have left over before your next prescription is filled?
Probably like 5 or 6.
And what do you do with those?
I just keep them.
Okay. So I'm wondering if it makes sense right now for us to think about, for the Valium, maybe what it makes sense for us to do is to find a way to get rid of some of that extra stuff. Do you ever find yourself needing more than one a day?
I want more than one a day some days, but I don't typically take more than one a day.
Okay. And is that a conversation then that you've had with your psychiatrist about that?
Yeah.
Okay. So I'm wondering if what we can do is come up with a plan so that you would get rid of your extra value. So in other words, you would just have what you need. And maybe what we could do, since, again, off script here, since I'm so worried about you and, the risk for suicide here, that maybe what we do is work with your psychiatrist to, instead of getting a month prescription, is that we do, I know it's a little bit more of a pain for you, but what if we did 1 week at a time?
We can try it.
Yeah. I mean, the goal, as I said, the goal here is to come up with a plan. You've got a lot of things that you shared with me in previous sessions in our intake about things that, you'd like to have some, excitement about and moving forward. And there's, a lot of things going on, and we want to make sure that you're available and around to do those kinds of things. And so what if we work with your psychiatrist to see about changing that so that you're getting them once a week, or 1 week at a time as opposed to 1 month at a time? Would that be okay?
Could we try 2 weeks first?
You know what? Why don't we do this? How about we work together and work with your psychiatrist to figure out what he or she thinks would be the appropriate amount? Would that be okay?
Yeah.
Okay. Quite honestly, and this is off script, I know that if you downed an entire bottle of Valium, we'd have a problem. I don't know how many off the top of my head you could take, depending on what your dose is, that would actually be too much for you. And so this is where we're bringing the physician in for this conversation. What we want the psychiatrist to know is that this is something that you have considered doing, and we don't want you to have enough in hand that if you ingested all of them, you would die. So that's the goal of what we're having this conversation about right now. But if you guys, as the behavioral health folks on the team, don't know the lethal dose, then work with the physician who's prescribing the medication to make sure that that person knows we can't allow a lethal dose to be available. So that's where we are with this conversation right now. And you know, I know that what'd you say, Lexapro, whatever the SSRI was that you said, I know that a month of that is going to make you feel crappy, but you're probably not going to die from that. So we're okay in that sense. But again, we want to work with the psychiatrist to have that person recognize that this is something that could be an issue for you, and therefore have them limit what you get. So that's us off script. So we go back onto script. What about guns? Do you have any guns in your home?
No.
You have access to a gun? Like, do you know someone who has one that you could readily get a hold of?
My brother has one, but I don't see him, and he lives like an hour away.
Okay. All right. Well, so let me ask you one last thing here then before we wrap up. I want you to finish this sentence for me. The one thing that is most important to me and worth living for is?
Making sure my mom's okay.
All right. All right. So what I'm going to do right now, okay, so then basically we would go through all of this and I'd say, all right, well, Lauren, we have this plan. We're running short on time, so I want to make sure that we all get to see this stuff too. And we have this plan. What might get in the way of you using your plan? And so we would have a conversation about those kinds of things and talk about, okay, well, you know, I may not have my plan. I may not use it in this situation. Okay, well, what can help support those kinds of things? The other thing would be, where are we going to keep your plan? You know, we've written all these things down together. How can we make sure that you have access to that all the time? I'll let you answer that. Let's pretend we're in the same room with one another right now. Like, what do we want to do with this sheet of paper? We've written all this stuff down. How can you have that with you all the time?
I could take a picture of it on my phone, and it could just be on my phone.
Okay. Yeah. And again, if for whatever reason you lose your phone or something, you delete the picture on accident or whatever might happen, you know, you can always reach back out to me. And what I can do is I can make sure that you have another copy of it that you can put on your phone. And so you would always have it with you. I think that's a great idea. Okay. So anyway, we'd solve those kinds of things. In Lauren's particular case, we wouldn't necessarily say, okay, let's bring your mom into the equation to make sure she's aware of all this kind of stuff, because it sounds like in that situation, that wouldn't be the most helpful thing. Like, you know, you're busy taking care of mom. she's going to struggle to kind of help you with these kinds of things. So we sort of wrap this up, you know, what's the likelihood that you would use your plan? We talk about that a little bit, and we'd kind of go from there. And then I'd, you know, make sure that you had a copy, you would take a picture of it, and I'd say, okay, great. So next time when you come in, we'll talk a little bit about this, and we'll see, you know, did you need your plan? How did it work? We always have the ability to change something. So if you find that there's something else that really works for you, we can add that to it. Or if there's something on here that you try and it just doesn't seem like it's really going to work at all, we'll take that off. All right?
All right.
All right. So Lauren, like, step out of character, go back to you. Did it feel like okay? Like, how did that feel?
When I'm doing a crisis plan with someone, it's a little bit different. It's harder to pull resources or coping skills. And to be candid, it's just another piece of paper that they have to do. So that's my biggest challenge with doing crisis plans, is that it's just a formality versus an actual tool to be used.
Right.
So it did feel a little bit different than when I've done them with clients in the past.
Yeah, I think the major I shouldn't say selling point, that's the issue. I think the major issue with it is when we set it up with people, there really has to be a sell almost, that this can be a useful strategy all those things, if you think about it, everything, let me share my screen so everybody can see what we came up with here. You know, here's, I gotta move us a little bit so I can grab it. You know, this is our list right here. So these are all the things that you said. You know, I stuck them in, I put the psych rehab support thing under 4. It's a weird kind of thing because it's kind of like, we know that's not necessarily something that in the immediate moment that might fall down to a step 5 kind of thing. But, you know, people are going to have these kinds of options. We want to throw them in certain places, but we also want to make sure that they've tried a lot of things to take care of themselves before they get there, which is why I put it kind of as far down as I did. And when you got to the people that you can ask for help, the first person you said was Teresa, and then you said your mom, and then you said your case manager, you know, and so we kind of work our way through that way. You know, then we get into the different places that you had. You had the warm line on here. The warm line's interesting, but the thing about the warm line, you could put the warm line as a step 4 thing if you wanted to. But what we know is if you call the warm line and you're suicidal, they're going to transfer you over the crisis number. And so somebody there is going to be able to work with you. So we know that the warm line can ultimately get you to safety if we need to do that. We added the other couple things you had, you know, making the environment safe. Oops, gas is not the right word. Station. You know, avoid the gas station, work with the psychiatrist to limit access to the medications, and then making sure your mom is okay was the #1 thing worth living for. So that's really what we came up with. And again, there are some medical records systems out there that have templates in there that you can already put these kinds of things in. You can always upload other things into the EMR if you guys are using those. If you're still in the world of paper and pencil, it's real simple, right? Stamp and in it goes. But what questions do people have about any of this? Oh wait, I saw a couple, something about the psychiatrist.
We received one question. When and how should you have that conversation with the physician?
Yeah, I think it's important to do one of 2 things. I would say in that meeting, so when Lauren and I are actually having this conversation, we're saying, listen, we need to think about these kinds of things. I would be like, okay, who's your psychiatrist? We might already know this information, but who's your psychiatrist? And then let's give this person a call right now. I'd call that person on the phone. I'd make them aware that this is an issue that we need to address. They may not answer it. I might leave them a voicemail asking them to call me back in relation to Lauren, and here's, you know, and she would sign a release. It's tricky when you're in different systems, but we're all working to keep Lauren safe. So I'd reach out, she'd be there with me. We'd have that conversation. If you work in a system where everybody's in the same EMR, for example, you can send them a message through the EMR. You want to let them know that this is a concern, because again, our job as non-physicians, the folks that can't prescribe medication, isn't to know and make the determination as to X number of pills equals lethal, and therefore that's our limit. But we do know from a medication standpoint, we want to make sure that the people prescribing the medications are aware that this is a potential overdose risk. And we want to make sure then that either the medication can't be lethal in the amount that is given, or a reduced amount is given such that those can't be considered lethal. PRN medications are terrible when it comes to these kinds of things, because, you know, here, you know, Lauren in this case is on Valium. Well, she might at the end of the month have 15 of those left over because she had a better than expected month and is feeling pretty good, and she's got 15 pills laying around, and now next month she's got 45. But if she doesn't use 15 next month too, now she's got 30 extra ones, plus the next month the prescription, now she's got 60. And then it gets kind of scary at that stage. And so the PRN medications are tricky, because if you don't use them, you just got a bunch of stuff laying around. So sometimes you need to work with the physicians to, you know, have them when she goes into her appointment. The problem now too is she's doing her appointments through telehealth probably, you know, but back in the in-person days, and hopefully in the future in-person days, you know, you bring your medication bottle in with you, and you turn in at the end of the month, turn in the leftovers and deal with it that way. Because if she wants to live, and this is the part we didn't dive into at the beginning, and it's really more of a time kind of thing for us, a limiting factor today, you really need to get into, this is something to help keep her alive. And if there are things that she's got worth living for, and as we had the conversation at the end, living for her mom, you know, those kinds of things are so incredibly important. We want to make sure she's here for that. We need her buy-in on this whole thing, because if she's not sold that this is something that's worth doing, she's not going to do it. Now, Lauren's also, her patient in this particular case is also somebody that we would be asking frequently, how's your mom doing? Because if her reason to live is her mother, and her mother has been pretty sick, we need to make sure mom's doing okay. And when mom's not doing okay, that's when we keep our eyes on her a little bit more. What other questions are there?
This one piggybacks off of the previous question. Let's say the client does not give us permission to collaborate with their psychiatrist. How should we proceed in those circumstances?
I'm trying to think if that has ever happened. You know, I think the person that doesn't collaborate or doesn't want us to collaborate with their psychiatrist is probably the person that I'd be wanting to know a little bit more about. You know, so let's talk about these things a little bit. Like, what's getting in the way here? You know, I'm not sold that they're sold yet on this whole thing, because if they were, this is a no-brainer issue. This is easy. You know, if they don't want us talking to their psychiatrist, that makes me believe perhaps there's something else going on that I don't know yet. And so I want to try to get into that a little bit more. I'm trying to keep her safe. And in the same vein, she's saying, you can't talk to the person that prescribes all these medications for me. Arguably, you're not breaking HIPAA by reaching out to the psychiatrist. Because if the goal of this is patient safety, and both of you are treating her, you have the right to reach out to that person and say, I'm concerned and here's what the issue is. Obviously, we would prefer Lauren to say, yeah, that'd be fine. But if she said no, I would say, you know, I'm concerned. Like, what's getting in the way of this? Like, this seems like a reasonable collaboration. Help me understand what you're concerned about. What worries you about me contacting your psychiatrist? Oh, they're going to change my medication. Like, this is a medication that works. Like, this is the thing that I've seen people, they're going to change the medication. It works really well for me. But because they give me so much, like, you're worried it's going to be lethal and then they're going to change my medicine. It's like, no. That's not necessarily what's going to happen. But we need to think through these kinds of things. You know, if they seem more amenable, but what's their fear? If their fear is the psychiatrist is going to do something like, oh, hospitalize them or something like that. It's like, well, if we work together on this, perhaps we can avoid those things. Like, this isn't a conversation about putting her in the hospital. This is a conversation about keeping her safe. And so we want to be on the same page about that, make sure that that's going okay. You know, but if ultimately she says, listen, nope, you can't talk to that person. I don't want you talking to that person about it. You know, that's when I pull out my old like HIPAA hat and say, listen, like, I appreciate where you are on this whole thing, but because this is a concern for me, I feel it's my obligation to talk to your psychiatrist about this kind of stuff. And because both of us provide care for you, I'm not really violating any HIPAA requirements by reaching out to that person. So I'm going to have to reach out to them. I just would like it if you'd be a part of that conversation because it's about you. It's important. But I think you can make the call if you got to make the call. It's just emergency medicine. You're allowed to call like somebody in the emergency room and tell them so-and-so is coming in. Here's all the stuff you need to know. Why? You're trying to save somebody's life. We're doing the same thing here.
Absolutely. Thank you. And one more question. How would we work with an individual that has a crisis developing and may need to go to a hospital setting with fears of being kept? Also, have you ever experienced with an individual who may not have had medication on hand, but went out and bought medication in a store or through the street? And how do we discuss that issue?
All right, good. I'm reading it on the thing because that was a lot. And I got to try to do this in 2 minutes. Let me see what we can do. Work with an individual who has crisis, may need to go to a hospital with fears of being kept. So in other words, a person doesn't want to get hospitalized, right? The thing about this is, as I said at the beginning, if somebody's at imminent risk, and that's my marker for needs to be in a hospital, then we're not doing this. That's something they should be doing in the hospital before they get discharged and sent home. Now, I know not every hospital is doing that, but that's if I had my way, that would be the requirement in Pennsylvania and beyond that. Everybody gets discharged from a hospital with a safety plan, like have something in place. So if the worry is they're going to get hospitalized, I think that's a completely different discussion. But the important thing to be talking with them about is this is about keeping you out of the hospital. This isn't about putting you in the hospital. The point of this plan is to help you utilize skills and strategies you had before that will keep you out. Now, if we get to the stage where we're at step 5 and nothing else has worked, I mean, the 2 people that called me, they ended up in the hospital out of 13, 14 years. Why? They knew that's where they needed to go. They tried everything else. They got to me. They knew that's where they needed to go. But if that's what the fear is about the whole thing, I think the narrative really has to be, this is about keeping you out of the hospital. So I think that's where that conversation starts. And again, if you're starting the conversation with somebody who probably needs to be in the hospital that day, we're not doing this. Ever experienced an individual who may not have had medication on hand, but went out and bought medication, Store Street, and how do we discuss the issue? This is similar to the antifreeze, right? So, or quite honestly, in Pennsylvania, it's similar to the gun issue. Is it possible that somebody could go and access something not in their house to end their own life? It doesn't matter if we're talking about medication or antifreeze or a gun. If you look at the data on firearm suicide, for example, what you find is that a very, very, very small number of people go out and purchase a gun, and within 2 weeks of that purchase, end their own life with that gun. What that tells us is, and if you look at the firearm data, and I'm only using that as an example because this is less lethal but similar concept, right? If you look at individuals who died by suicide using a firearm, the vast majority of those people had the gun in their house. A significantly smaller number of people went somewhere else to go get the gun, not buy it, but somewhere else to go get the gun from somewhere else to use it. People are less likely to get up, leave, go somewhere else to get something in the middle of a crisis than not. So is it possible that they may go get some medication to overdose? Yes, but similar to the conversation that we had with Lauren, what we want to do is talk about, all right, there's certain things we might need to avoid. If we're using your safety plan, we're avoiding certain things. This is the same thing for things like, train tracks and bridges and stuff like that. It's like, we don't go walking on the train tracks when we're using our safety plan. Like, that becomes part of the conversation.